Good morning. The literature on spontaneous intracranial hypotension focuses mostly on diagnosis and treatment, but there is no controlled studies to optimize the post-epidural blood patch treatment of patients. Thus, Dr. Shivink commissioned a survey of centers that perform epidural blood patches. My name is Charles Louy, and Rachel Cruz and I will discuss the results of this survey. Oh, let me see, something is wrong. Okay. Oh, okay. So neither of us have any financial disclosure. I'm also a member of the medical advisory board of the Spinal CSF Leak Foundation. 21 centers responded from across the United States, Canada, Europe, including the United Kingdom, New Zealand, Australia, and Taiwan. I will discuss the results on limitation of activity levels and analgesic management. Rachel will discuss travel restrictions, prevention and management of cough, nausea, vomiting, constipation, rebound intracranial hypertension, and how to manage expectation and success of treatment. Let's start with bed rest, which is the most immediate restriction that we usually impose on patients after epidural blood patches. As you can see from the result, one center does not impose any kind of bed rest, and we go all the way to 3 centers imposing 2 days of continuous bed rest. One center recommends up to 3 days of strict bed rest, provided the patient doesn't have any risk factors for deep venous thrombosis. And 2 centers recommend 3 days of bed rest mixing with light activity. The mode landed at 1 day as recommended by 8 centers. I divided the activity level between light activity and the no bending, lifting, twisting category. In terms of light activity, the minimum required is 3 days, and it goes up to 4 months as recommended by another center. The mode landed between 4 and 5 weeks as recommended by 5 centers. So when we talk about no bending, lifting, twisting, what is the recommended duration? The shortest duration recommended has been 1 week as recommended by 2 centers. And then it goes up all the way to 4 months. Another center responded defined it as quote, as long as possible, with one center recommending that patient with joint hypermobility syndrome avoid any activity in the BLT category forever. And 2 centers ban jumping and chiropractic manipulation also forever. The mode landed at 2 weeks as recommended by 7 centers. So when we talk about no lifting, what kind of weight are we talking about? The lightest weight recommended is between 4 and 5 pounds as recommended by 3 centers. 1 center allows patients to lift weights up to 20 pounds. The mode landed between 9 and 10 weeks as recommended by 7 centers. In terms of sexual activity restrictions, 1 center recommend avoiding sexual activity for 4 weeks. 2 centers allow sexual activity as long as the couple assumes the woman on top, man on bottom position. And 1 center, on the other hand, recommends that the patient affected by SIH remain at the bottom during sexual activity. 17 centers did not address this issue. So much for activity level. Before I move on to the analgesic management, let me briefly describe what we do at Cedars-Sinai, because I think it's a little bit different. As soon as the patient arrives in the recovery room, they are given 1 gram of oral acetaminophen, 300 milligram of oral gabapentin, 50 milligram of oral tramadol, and 500 milligram of oral metocarbalol. And all these medications are to be given simultaneously for maximum impact. We repeat this multimodal analgesic regimen 4 hours later, and by the time patients are discharged from the hospital, we recommend they only use acetaminophen for pain on an as-needed basis. Let's go over the results of the survey. Starting with non-steroidal anti-inflammatory drugs, 48% of the centers allowed their patient to take an NSAID immediately. 5% recommend the patient wait 2 weeks before taking an NSAID. 5% said wait 1 to 2 months, and 10% said avoid NSAID but did not specify the delay. Finally, 33% of the centers do not include an NSAID in their analgesic regimen. Oh, what's going on? In terms of gabapentinoid, 57% of the centers do not include either gabapentin or pregabalin in their list of analgesics. 14% of the centers are totally against NSAIDs. 24% said yes, and 1 center said in the recovery room only, and that's Cedars-Sinai. I'm sorry, I'm having problems here. Okay. In terms of muscle relaxant, 2/3 of the centers do not include muscle relaxant in their analgesic regimen. 10% of the centers said no, 19% said yes, and 5% said yes in recovery room only. What about heat or cold? 52% said yes, 10% said yes in but heat only. 5% said no heat for 24 hours for fear of inducing a false fever, and 5% said no. And finally, 29% did not specify either way. Acetaminophen was the least controversial of all the analgesics. 58% of the centers said yes, 42% did not specify it, and nobody was against it. As any survey, there are limitations of the result. The most important one being the lack of independence within the responses, since centers communicate with each other as they should. Also, I was not able to stratify the result between high volume epidural blood patches, during which patients received blood until they developed radicular pain, versus standard volume epidural blood patches versus targeted epidural blood patches. And even though in quantifying the result, I tried to be objective, I probably lost some nuances. Nevertheless, I hope the results are interesting to you. And thank you very much for listening. I'm going to switch laptop with Rachel.
Thank you, Dr. Louy. Good morning, everyone. I will be talking about, let's see here, travel restrictions post-treatment. So as Dr. Louy had mentioned, we surveyed about 21 CSF leak centers across the world, and all of the centers agree that both driving or flying are both safe modes of transportation post-treatment. One center in Germany mentioned traveling by train. So I divided the results into short distances and long distances. Short distances is defined as a 1 to 2 hour time period. So 14 out of the 21 centers had no specific recommendations after their mandatory bed rest. One center admitted patients on the day of the procedure, and that's a center in Germany. 3 centers recommended no driving the day of the procedure, including Cedars, and that's because we do our percutaneous treatments with anesthesia. 7 out of the 21 centers recommended to lie flat when they're driving, and 4 out of those 7 centers recommended to avoid bumpy rides. Interestingly, 1 out of those 4 centers recommended to avoid bumpy car rides for at least 15 days, and that's a center in Italy. One center mentioned, and this is a center in the UK, that patients are unable to lie flat because of the seatbelt law, One center recommended a foam mattress in the car as a shock absorber. And then one center recommended to be wheelchair down from their hospital bed to their car, climb slowly into the passenger seat, recline the chair to 45 degrees, and then as soon as they get home, lie onto the couch bed or a recliner. So for long distances, and this is defined as more than 2 hours, 9 out of the 21 centers had no recommendations after mandatory bed rest. 2 out of those 9 centers only have local patients, so this question was irrelevant to them. Only one center out of all the centers recommended no air travel for 1 month, and that's a center in Italy. 7 out of the centers recommended to stay at a local hotel on the day of the procedure or the day after. And then 4 centers recommended to stay at a local hotel 2 days after the procedure or longer. So moving on to prevention and management of cough. So all 21 centers do not recommend preventative or prophylactic treatments of a cough. In fact, 6 out of the 21 centers mentioned that coughing is not a problem in their practice, and 2 out of those 6 centers are international. However, it's important to consider that preventative treatment for patients with a history of respiratory illnesses, or if they're taking medications that can cause a cough. The majority of the centers, so 8, recommended to manage the cough as needed. The majority of the centers recommended over-the-counter cough suppressants or antitussive agents listed here, such as cough lozenges or dextromethorphan. And then individual centers had their own protocols, so codeine, Tessalon pearls, and levodopa, which is a medication abroad. And 13 centers had no specific recommendations to manage cough. So moving on to prevention and management of nausea and vomiting. So again, we surveyed 21 centers. 2 out of those 21 centers find that nausea and vomiting are not issues in their practice, which I thought was very interesting, and they had no specific recommendations, and both are international CSF leak centers. Only 1 center recommended both preventative and as needed treatment. So this particular center gives patients IV ondansetron or Zofran and diphenhydramine Benadryl prior to the treatment, and every patient receives a prescription for Zofran ODT and Phenergan suppository post-treatment. The majority of the centers, so 19 of them, treat nausea vomiting as needed, and the majority of the centers prescribe antiemetic therapy, and particularly ondansetron or Zofran 4 to 8 milligrams. And that's 13 out of the 19 centers. So 1 center is cautious with prescribing it, given that it can induce constipation. 1 center advises patients that it can reverse the effect of tramadol at the 5-HT3 receptor. And a center in Germany rarely prescribes Zofran, which I thought was very interesting. 1 center recommends ginger tea or food to treat nausea vomiting post-treatment, but no supplements given the antiplatelet effects. And then as you see here, there's individual cocktails that they use for nausea vomiting. 1 center recommended hydration, and then 1 actually admits patients to the hospital. So moving on to prevention and management of constipation. So again, we surveyed 21 centers. 4 out of those centers recommended preventative and prophylactic treatment of constipation if it's a known issue with the patient. So 2 out of those 4 centers recommend daily polyethylene glycol or Miralax. Then as you see here, 1 center just prescribes docusate sodium, and 1 center does a cocktail of Senna, Colace, or Miralax for 4 weeks if the patient is prone to constipation. But all the centers recommend treating constipation as needed. Interestingly, in Taiwan, they don't find that constipation is an issue, likely due to their diet and culture. And then 3 centers had no specific recommendations. The majority of the centers recommend laxatives, as you see listed here. 3 out of the 17 centers actually prescribe lactulose, which is, one of the stronger medications. And then only 2 centers out of the 17 recommend to avoid laxatives that can cause abdominal cramping post-treatment. And those laxatives include Biscodol, Senna, or enemas, although some centers actually prescribe them as first or second line treatments. And then of course, here we have other bowel regimens that other centers recommend. So in addition to laxatives, 1 center recommended adequate hydration, 3 centers recommended to avoid opioids unless the patient is having severe pain, and then 1 center recommended a diet rich in dietary fiber. So moving on to rebound intracranial hypertension, as the previous speakers have discussed, only 2 out of the 21 centers treat RIH prophylactically before their treatment. So one center prescribes acetazolamide twice a day following a glue patch for CSF venous fistula, and that's based on Dr. Mamluk's paper, who he'll discuss later. And one center preemptively starts all patients on Diamox twice a day. Otherwise, 6 out of the 21 centers recommend managing RIH based on the severity of their symptoms or treating it conservatively. So one center reassures patients that the cases are transient, that it takes some time unless it's severe. And as Dr. Knievel mentioned in her lecture, that you have to look at other differential diagnoses such as cerebral venous sinus thrombosis. And then interestingly, one international CSF leak center found that most of their patients only have mild RIH symptoms, and they respond well to acetaminophen and sometimes NSAIDs. So 4 centers recommend to elevate the head of the bed. 3 recommend to restrict caffeine and salt. 1 center recommends to reduce hydration to pre-CSF leak levels. 1 center emphasizes that foods with carotenoids do not need to be restricted. This is a myth. And then, of course, 4 centers recommend dandelion tea and capsules. And it's good to note that the leaves actually have the diuretic effect. So if RIH is moderate or severe, 19 out of the 21 centers recommend carbonic anhydrase inhibitors as first-line treatment. And that's, of course, acetazolamide or Diamox. And the dose varies by practice, as you can see here. Interestingly, one center recommended to avoid starting Diamox sooner than post-procedure day 1, and they increased their dose by 250 milligrams every other day to a max of 1,000 milligrams twice a day. At Cedars, we do a max of 1,000 3 times a day. And then one center starts patients on Diamox 1,000 milligrams at bedtime for 1 to 2 months if they have a high pretest probability. And that criteria includes papilledema in the past, a BMI over 35, if they have a known history of obstructive sleep apnea, or if they have a known bilateral transverse sinus stenosis. And then they taper off and then have them see ophthalmology. So if Diamox is prescribed, all 19 centers who use Diamox as a first-line treatment, they supplement potassium and sodium bicarb as needed. One center actually monitors magnesium due to the urinary losses. And interestingly, only 3 centers consider methazolamide as first treatment because it's better tolerated. And of course, the dose varies by practice. 2 out of the 19 centers consider topiramate as first-line treatment with or without acetazolamide. And this one particular center, if they do prescribe Topamax, they also prescribe potassium citrate to prevent kidney stones. Other medications to treat RH include furosemide. 4 centers use it as a first-line treatment, 3 centers use it as second line, and 1 center uses as a 4th line. And 1 center uses Topamax as a second-line treatment, and 2 uses the medication as a 3rd-line treatment. 3 centers recommend lumbar puncture as the last resort. 2 recommend an ophthalmology evaluation, and 1 actually admits patients for opioid pain relief if their symptoms are severe. And lastly, managing expectations and success in treatment. So out of all of the survey questions, the results of this particular question was very different, but I managed to extrapolate the most common themes out of all of the answers. And one of them is having an individualized plan and follow-up. Interestingly, one center in the UK reports that patients are very grateful since there aren't many local centers in the UK that treat SIH. And then the video follow-up and the follow-up calls varies from practice to practice, as you can see here. The second most common theme I found is that a lot of the physicians and providers, they reassure patients that there's no quick fix and that it's a long process, it's a slow road to recovery, and that repeated therapies is necessary, but don't give up. So one center mentioned that they use cautious optimism with the caveat that repeat interventions may be needed. One center tries to provide hope and optimism for improvement, but they're also realistic that some patients will not improve, partially improve, or may require multiple treatments before they even improve. Furthermore, one center underscores that these symptoms are real and that this is one of the most disabling conditions that the provider has ever treated. One center tells patients that there's gradual improvement expected over the course of 6 weeks with continued improvement over 12 weeks thereafter. And they have a specific protocol if their symptoms return. And that, of course, varies from practice to practice. And the third most common theme is that frank and realistic discussion about the success rate of treatment. So one center tells patients that they may feel worse before they feel better, particularly with regards to RAH, but it's a good sign. One center distinguishes between what symptoms are due to CSF volume depletion and which are not, or not maybe. And then a symptom checklist, which symptoms improve or worsen after the treatment. Furthermore, one center quotes a 30% success rate after treatment if it's unclear that the patient has a CSF leak, and that success rate increases to 65 to 70% with repeated patching. One center tells patients that the goal is to improve symptoms and MRI abnormalities, and then one center offers realistic expectations depending on the possibility or probability of a CSF leak. Moreover, with that theme of being realistic, one center tells patients that it really depends on the type of CSF leak as far as the success rate. This provider is more optimistic if it's a post-dural CSF leak versus a dural tear. And then one practice tells patients that symptom recovery is based on the duration of symptoms. So the success of treatment depends on the leak, the type of leak, the cause of the leak, and if the leak is isolated. And the same center tells patients that some symptoms may be permanent or it may take longer to recover. And then one center does not quote percentages of success rates at all. They tell patients that surgery may be necessary depending on the type of leak they have. They tell patients that there's a mix of data on the effectiveness of patching if they have a CSF venous fistula, and that repeated treatment may be necessary before considering surgery. One center quotes a 70% success rate with the first attempt. I thought that was pretty interesting. And then one international CSF leak center discusses potential benefits and risk of other treatment options that are more or less radical or experimental if the patients are not happy with their recovery after their treatment. And then another international CSF leak center reassures patients that their headache should disappear immediately, and then a second blood patch is rare. And then the fourth most common theme among the answers was, of course, the support and resources, which, our colleagues have addressed before in the previous lectures, that the Spinal Fluid Leak Foundation is a great place for resources. And again, as Dr. Louy mentioned, the limitations of the results. In the survey, we did not specify the type of CSF leak the patients may have, or objective or no objective evidence of a leak, so that may skew the data. And then, of course, all the centers communicate with one another, so there's lack of independence. So in summary, post-treatment considerations are variable. There's no preferred mode of transportation post-treatment. Generally, the centers do not prescribe preventative or prophylactic treatment of coughing, nausea, vomiting, constipation, or RAH. They treat it as needed. Management of expectations and success of treatment is approached with cautious optimism and realistic goals. And of course, treatment of a leak is a long process. There's no quick fix, but we are all here guiding you guys every step of the way. And thank you for listening.
Thank you, Charles and Rachel. Great practical talk that really highlights some of the commonalities, but also some of the variabilities across centers around the world, as we are all trying to learn more and learn what is the right thing to do or the right things to do.